Welcome, everybody. So glad to see everybody on our APA Lifestyle Psychiatry monthly webinar. I'm Dr. Gia Merlot. I'm the chair of the caucus, and we've been doing this ever since this caucus has formed. It's been such richness about what we've learned today. I'm very excited to introduce a colleague and friend, Dr. John McHugh. He's a graduate of Columbia College and Harvard Medical School. In 1995, he followed his childhood dreams. He moved to California and trained in OBGYN. Somebody is not muted. Let me just see if I can mute you. Okay, got it. He followed his childhood dream, moved to California and trained in OBGYN at the University of California in San Francisco. He has been the faculty of UCSD, UCI, and USC medical schools, department chair of Scripps Mercy Hospital in San Diego. He serves as chair for the American College of OBGYN District 9, California and Ecuador. That's an interesting matchup there, representing over 6,000 physicians. He is on the leadership, and I've served in many committees with him, co-founded the Women's Health Group for the American College of Lifestyle Medicine, very well published, and he's going to talk today to us about sleep and women's health. Welcome, John.
Thank you so much, Gia, for that introduction. I just want to check with everybody. Is audio okay and video's okay? You're all able to see things, I hope, out there. I really appreciate this opportunity to talk to you all, but I have to say, as I was saying to Gia earlier, I come into this talk with great humility, not just as someone who wants to teach, but also someone that wants to learn. So I'm really hoping we have some really good dialogue at the end, things I can learn from you as specialists in mental health. You have such a wealth of knowledge. Some of the slides that you'll see in this talk were aimed more for an OBGYN audience, but really what I hope is I left them in that format so you can help me in terms of things that I can talk to my colleagues about. I will mention a couple of those letters there on the screen. In OBGYN, I am a fellow in OBGYN, but really one of the highest honors in my career has been to become a fellow in lifestyle medicine. I think it's really something that matters to me. It's the foundation of why I went to medical school, and I'm overjoyed that the psychiatrists are embracing this. I'm working on the OBGYNs. We've got our national president coming to the meeting in the fall, and we're hoping to bring along my colleagues as well with that work. A couple of the basic slides. I have no financial relationships with any commercial interest to disclose. But I would like to, if anybody knows a good mattress manufacturer for some of this sleep work, I'd love to build a relationship with them. Learning objectives. I really do want to talk about the prevalence of inadequate sleep among women, specifically in America, but we will talk also somewhat more generally. But something that I was not taught in medical school, something that's come out of this women's health group, and I've also been a leading member of the sleep group within lifestyle medicine as well, looking at its effect on some of these common conditions like preeclampsia and polycystic ovarian syndrome, at least common in my practice. Maybe you've come across these now and then. Also looking at the non-pharmacologic measures, where I feel like I'm qualified to speak is up to the point of pharmacologic measures, and then I defer to my colleagues to really get into if they do feel like a patient needs pills to be able to get there. Gia covered most of this. I was actually going to put this on the slide and just say yada, 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 because this isn't really the introduction that I want to make for myself. I think it does give a little bit of background to how I got here, but more importantly, kind of, again, expressing some of my humility as a patient. Here's the truth about me. I did get up to, I was nearly 90 pounds heavier at one point in my career. I was on the cuff. My primary care physician said I should start hypertensive medicines. I had acid reflux, which did get reversed. And I did do a sleep study at that point. This is 2013. And at that time, I was 12 years younger. They did recommend CPAP at that time. I had the lowest quartile of a sleep score. And if you look at this picture, it expresses it all, right? I've got a cup of coffee and two devices in front of me at the same time. And I can't say that my abs would make the cover of a swimsuit magazine at that point in my life either. When I really focused on the lifestyle causes, I really did address those and really did. I would say that we as OBGYNs, when we walk into a room with dark circles under our eyes from our sleep deprivation, really have very little credibility with our patients. And so I embarked on a phase of my career where I tried to learn that. So I love this quote: we teach best what we most need to learn. So some of this, and for many of my colleagues in lifestyle medicine, many of us have been on a personal journey as well as a professional journey with this. And I invite all of my colleagues to embark on that journey with me. Um, so here are two ways to look at lifestyle medicine. Here are my two favorite definitions. The old school one from AD 50 is really beautiful and I think somewhat poetic. Live in rooms full of light, avoid heavy food, be moderate in the drinking of wine, take massage, baths, exercise, and gymnastics. Fight insomnia with gentle rocking or the sound of running water. Isn't that what we have with white noise on our iPhones now? Change surroundings and take long journeys. Strictly avoid frightening ideas. Indulge in cheerful conversation and amusements. And most importantly, listen to music. So people were on it back then. We've kind of simplified it and kept it less poetic. This is a T-shirt that I got. I hope they bring it back at the lifestyle medicine meetings. Eat plants, keep moving, sleep well, be present, stay calm, love people. So these are two different ways to take that message, but let's hope we can take some parts of that message to heart and incorporate it into our practice. The question I asked him, we don't have any polling mechanism here. We don't have a way to kind of raise our hands or show our hands here. But when I asked my colleagues, am I getting optimal sleep? Really, only the retired physicians raise their hands on that one. When I'm not on call, I sleep well. Those who don't take call often sometimes get to that point. But I'd say almost all of my colleagues in OBGYN answered either C or D. And I, for myself, with my obesity and hypertension, had a health problem exacerbated by inadequate sleep. I think now I'm getting to a point where I generally sleep well when I'm not on call, but
So
still sometimes have problems.
John, we can put something in the chat. I'm going to put my answer in the chat.
Sure.
So just
Great. That'd
for
be great.
accountability. So no, you don't have to, but I'm going to start. And whoever has the courage. So
Yeah, that would be great, Gia. And then I won't probably be
there
taking
you
a look at
go.
it while I'm speaking, but then at the end of the
Okay.
talk, we could go back to
Oh,
some of those ideas as well.
perfect. We're all C so far, but please keep going.
Oh, good. Okay. So we'll see. Also, we got a few more questions here, and I'd love to see both how this group answers and then also compare it to how my OBGYN colleagues tend to answer these questions. Um, This is a book I would highly recommend. I know it's been a big New York Times bestseller, but not everyone's read it. It's been to me, one of the most important books that I've read looking at some of the issues within lifestyle medicine. Matt Walker also does a masterclass, if any of you have that masterclass series on sleeping, and also a few TED Talks on sleeping as well. Really opened my eyes to some of the questions about sleep. Generally defined as 7 to 9 hours a night for adults. And I'll get into a little bit as we use Apple Watches to track it. Maybe some of those numbers will shift. Second question is, are we having efficient sleep? And more than 85% of the time one spends in bed should be asleep, not tossing and turning. We should have less than or equal to 2 awakenings a night. Insomnia defined as the difficulty with the onset
Is
or
Madison there?
maintenance of sleep.
Yes. Okay. Have you done vital?
I got it, John.
Okay, great. Thanks. And REM sleep, it's fascinating how much it changes over the course of our lives. It's about half of a newborn's sleeping time, comes down to about 20% for an adult. And it's been fascinating when people have been deprived of REM sleep, and this audience may well know it, um, the impact on learning, memory, and mood the next day is really profound. Non-REM sleep is a time predominantly for tissue repair and regeneration, but these boundaries are not firm. Then we use these two different terms. Sleep hygiene is the term that's most often seen in the literature, but I think a better term is sleep preparation. How do we prepare ourselves for sleep? What are those practices and habits that we're getting into? So I just wanted to define a few ideas as we get further into it. Are we getting enough sleep? A third of Americans don't get adequate sleep as defined by those parameters. It seems as though we were doing better before the electric light bulb. And then after the electric light bulb started coming, the television and different devices, and our sleep continues to decrease to we've lost somewhere around 1 to 2 hours of sleep per night. Women are more likely to report insomnia, whether that is they're more willing to talk about what's actually happening, or whether they're suffering from it is somewhat of a question. And some of the causes, especially in perimenopause, can be hot flashes and night sweats, which can awaken women. Depression and anxiety are also more common in women. We'll talk a little bit more about the bidirectional nature of some of these conditions with sleep disorders. So when I don't know how many of you work with pregnant patients, but are we getting enough sleep in pregnancy? And the answer is it starts bad and it gets worse. The most commonly used index that I've seen in the research literature is this Pittsburgh Sleep Quality Index, the PSQI. Healthy sleep score should be less than 5, and across the board, pregnant women are over 6. That doubles by the time we get to the 3rd trimester. And most women report disturbed sleep when they're asked. The question is, are they being even asked? Are they even thinking this could be something unusual that they should be bringing up? And the answer is probably no. And beyond pregnant women, who else is at risk? I find this data fascinating, and if anyone has insights into it, I'd be really curious to hear if anyone has seen this. But Black Americans have shorter sleep duration, independent of education, work, and any other comorbidities. Multiple areas in sleep quality are worse. We also see it in people who do shift work. So OBGYNs and labor and delivery nurses are top of that list. They also have job-related stress, but probably any group of physicians is having extended work hours. You can't necessarily determine when a consult's going to come in. That could affect your commute. And this is really where what we're seeing is people are shifting to less sleep and giving it up for both time in the car and time on screens. Postpartum, almost half of women have no support with a newborn child. So you're absolutely, by definition, getting more than 2 awakenings a night if you have a newborn child. And then patients who are obese. And we'll talk more about obstruction and apnea and things like that, but definitely more sleep disorders. And probably with PCOS, we'll also see other problems like circadian rhythm disturbances. This is troubling, and this is really something we actually formed a national wellness committee under American College of OBGYN to really try to look at some of the issues that are impairing wellness. But what are the risks of night shifts? Hopefully, this group does fewer night shifts than my colleagues do. It's definitely associated with impaired sleep. As we said, sleep is sacrificed. What are the risks? It's classified as a 2A carcinogen, night shift work, which means probably carcinogenic to humans. I think that's better than processed meat, but about the same category as red meat for probably carcinogenic to humans. And there actually was a class action suit in some Scandinavian countries for night shift nurses to get payouts for increased cancer rates. It's something really we should be thinking about as a medical profession, what we can do to make life better for our colleagues. So I want to shift a little bit, pivot a little bit into how we're screening and also then talk about some of the problems. I think the watches and the devices are, well, they're certainly putting out a lot of data. The question is it good data? And then secondarily, can we use that data when we get it? This was a study published in 2020 looking at the Apple Watch specifically and comparing it to polysomnography. 100% sensitivity, 90% specificity for looking at apnea. And I'm finding it, this is my own data from my own watch. If you look here, the central blue is basic sleep. When we're going up into the light blue, that is REM sleep, and coming down into the dark, almost purple, that's non-REM sleep. And I'm seeing also in orange the awakening. So clearly, I'm sharing with you my data. I have more awakenings than I should. It looks to me 1, 2, 3, 4 awakenings during that sleep, but I am having periods of REM sleep there as well. What I'm seeing, and I haven't seen this validated in the literature, again, I'd be curious to hear what other people have seen, is that the watch is very efficient at subtracting out those awakenings. So in general, people who may feel like they're in bed 7 to 9 hours are maybe getting somewhere in the 6-hour range of sleep. The apnea data has been validated, and seeing those sleep disturbances is there. So it's something I think we could start thinking about for our patients if they have data from a wearable, trying to bring that into our practice and use that as our first line screening. What I'm seeing when I ask people, I just went to a menopause conference the other day, they don't have a validated screening tool. They're asking very informally, how's your sleep? And I think we can do better than that. Unfortunately, ACOG, my organization, is not doing better. We actually don't have sleep in the standard antepartum record. We don't even bring it up. And ACOG has done so much work on what they call redesigning the cockpit. So when we have a problem, think about fixing the tools that we use, think about fixing the data coming in, but we're not even asking about this data. And most of our patients who are having trouble sleeping in pregnancy just assume this is normal, and there are simple interventions we can do to improve their outcomes that we're missing. So this was my question number 2. Maybe I could ask anyone who's been pregnant or part of a pregnancy, did it come up? Did anybody ask about your sleep patterns during pregnancy? When I've asked my OBGYN colleagues, I've usually gotten answer B, less than half, which might mean 10% of the time. So Gia, we're able to put that into the poll if people want to put in for
Yeah,
question
they're
2.
already putting it in, so everyone's saying A, never. So
Never.
the ones that have responded have said A.
This is
Let's
something.
hear what Tiffany has to say. Tiffany, you've had some. Is she
Oh,
still here?
for mine, yes. I think that I said D on the first one, which I don't remember what it meant, but
This
probably
one.
that I get poor sleep that has led to some sort of
Medical problems.
yeah,
Yep.
medical problem. And it's only unfortunately during I am in graduate school for a business school for MBA also in addition to working. So I think my sleep has taken a pretty big hit, but I do try to prioritize when I can.
All right, thank you.
Thank you. Let's hope we can share all, we're going to share the toolkit that we have and get some new ideas from the audience as well. Hopefully we can come up with some ideas. Great. Thanks, Gia. So what are the risks? Well, certainly motor vehicle accidents. When we poll women, about a quarter of women drove drowsy in the last month. And about 1 out of 10 times when they were doing that, they had a child in the car at the time. We know it's a significant contributor to motor vehicle accidents. We'll talk more about hypertensive disorders of pregnancy. That's about 1 in 7 pregnancies in America right now. We'll talk about how it affects the immune system, talk about how it affects labor. And I think I should probably have amended this slide. I'd move infertility from potential to actual. We have clear data on infertility and sleep, both in men and women. But it's been linked possibly to miscarriages, to preterm delivery through what we call oxidative stress by that hypoxia. But think about this as well. What is the impact on the fetus if the mother is having frequent episodes of hypoxia during the night? There is some potential link to small for gestational age, stillbirth, and possibly even long-term neurological effects on the fetus. So we've really got significant effects from recurrent insomnia and sleep apnea during the night. This is a study which I don't think could get through an IRB today, although it looks like it wasn't really all that long ago. Took patients, I think these were undergrads. I think this was study done in Pittsburgh. What they kept constant was the fact that they dripped live rhinovirus into their noses and gave them a dose of rhinovirus. But what they varied was the amount of sleep that they got. And looking at those who slept less than 6 hours a night versus those who got more than 7 hours per night, there was a 450% increase in the likelihood that that turned into a clinical infection. And this was independent of controlled for other variables, body mass index, health practices, et cetera, et cetera. So we know that sleep deprivation has a very profound impact on your ability to get sick. And when people were doing everything under the sun for COVID, I think many of us were not addressing our sleep, which we should be addressing, certainly. Women in sleep apnea. Sleep apnea is probably the most common manifestation of sleep disorders, but they're 2 to 3 times less likely to have classic symptoms. So they're often missed with screening. And this is, again, where a wearable may be more objective. They do report insomnia, headaches, often some vague symptoms that could be mistaken for depression. Turns out their daytime functioning is equally affected. What it does seem, and I really attribute my colleague Cindy Geyer, who helped found the Women's Health Group with me, really talks a lot about this upper airway respiratory syndrome, where they're having brief obstructions, but not the same airway obstructions that men will have. I will tell a little bit of a side story. One of my favorite sports is skiing. With the group I go with, sometimes they put me in the bunk room with 8 other men of my age and weight. Um, it feels like farm animals are being suffocated with the sound that some of those men make. One of the most common causes of female insomnia is a man who snores lying next to her. I'm sensitive to that, having gone on those ski trips. The traditional diagnostic criteria for sleep apnea doesn't work as well for women, but women who do have snoring with obstructive sleep apnea have about a 4.5x higher risk of metabolic syndrome, diabetes, hypertension, and sleep apnea increases significantly in the perimenopausal period. So it's really something we should be sensitive to and aware of and screening for in our practice. You all probably all know this. All psychiatric conditions have an associated sleep disorder, and the relationship seems to be bidirectional. So that treating the sleep can improve the psychiatric condition and vice versa. Sometimes sleep changes do precede the onset of bipolar disorder, and we do see obstructive sleep apnea much more commonly. Gia, this has come up on some of our recent discussions in psychiatric illness. 90% of patients with PTSD do have insomnia. And I would like to talk a little bit more as we get closer to the end about cognitive behavioral therapy for insomnia. I think it can be very effective and can also hopefully address the baseline health for these patients and maybe make them more amenable to treatment. Going back into some of the more specific OBGYN issues, sleep clearly affects ovarian function. The question is how? Is it a direct effect? Is it an effect of the circadian dysrhythmia? Or is it related to this chronic stimulation with these apneic episodes of the adrenal axis? We really don't know which of those it specifically is, but they've all been postulated as causing this effect. What we do see is that here we go back to nurses with rotating shifts. They do have more menstrual cycle irregularity. That's clear. And that's purported to have a risk for their infertility. But the second study done 7 years later really shows that in a large 16,000 patients and 33,000 controls with non-apnea sleep disorder, about a 3.7 increased risk of female infertility compared to their cohort. So sleep should definitely be addressed. And I think our infertility specialists, they have longer visits. I think they're doing a better job of addressing these issues than we in doing prenatal care. We see that women have decreased ovarian reserve if they're in a fertility treatment. So it's really important if you're trying to have a successful fertility treatment to address the sleep cause. Women with diminished ovarian reserve are 3 times more likely to report diminished sleep. And infertile women with diminished ovarian reserve are 20 times more likely to experience disturbed sleep. So we're seeing this happening across the board and really something that needs to be addressed in our society. One of the most complex, and I don't know if any of you have looked at this, is polycystic ovarian syndrome and its relationship to sleep. This is the most common cause of female infertility. It's related to obesity. It's related to diabetes and hypertension, but it seems like it does have a bidirectional relationship. And it's not simply about obesity. It seems like there's something specifically in polycystic ovarian syndrome which does trigger sleep disturbance. We see it as a severe metabolic stress with elevated insulin resistance and high blood pressure that cascades into oxidative stress, and that may have the impact on the ovary itself with that. It's really a fascinating condition. Sleep and male fertility, what's good for the goose is also good for the gander. We see that men who have more sleep disturbances have a 25% lower sperm count and less morphologically normal sperm than men with less disturbed sleep. So we're seeing it for men as well. And I think for our infertility colleagues, they should be addressing it, screening for it, and referring, if needed, for sleep disturbances. Specifically within pregnancy, What are we treating? One of the problems I have with some of my sleep colleagues is they go directly to sleep apnea and CPAP. It's sort of like my infertility colleagues go directly to IVF when there can be many, many reasons that are there. They look at the world a little bit too simplistically. I think in the lifestyle medicine world, we look more holistically, and we're talking about some of these conditions. Restless leg syndrome is seen in about 1 in 4 pregnant women, causes movements of the legs at night. And we do have some nutritional things that can be done that I'll talk about in a minute for that. So we should be trying to bring that up. The challenge with restless leg syndrome that I've seen is people aren't aware of it. They don't know that that's happening to themselves. Sometimes we have somebody who's observing it, seeing that they're having leg motion before they awaken. Acid reflux is incredibly common in pregnant women. Some of this is hormonal, but mostly it's simply pressure of the growing fetus on their stomach, pushing that acid higher up. So I'm lucky. I work as a laborist often when I see patients, and when it's quiet, I can spend an hour talking to them. And many of them have never had counseling about acid reflux, about dietary changes. They've gone straight to taking pills, which they don't want to take in pregnancy. But we can talk about simple dietary changes, small, frequent meals, avoiding meals just before going to bed, and avoiding meals that stimulate acid. Nocturia is an issue that I have to say I kind of give up on with pregnant women. There is no way a pregnant woman is not going to get up at least twice during the night to go and relieve herself. And I think that can be par for the course. However, I think trying to avoid salty food, trying to empty their bladder before they go to bed can help, but it's probably not going to ever get them down to less than twice in a night. I'd say we as OBGYNs are not doing a great job of screening for depression and initiating treatment when we can, but it's very common especially in the postpartum period. And it does have as well a bidirectional relationship with sleep where hopefully if we can treat both, we can make both of them better. So this is a cartoon showing airway movement and some of the areas where we see obstruction coming into our patients. But I'd broaden this obstructive sleep apnea to something called sleep disordered breathing. So it's going from snoring to OSA. Obstructive sleep apnea is about 1 in 5 women in the 3rd trimester, and that cascade. They're getting oxygen deprived, it's creating inflammation, and that's causing their blood pressure to go up. And this seems to be something that's triggering preeclampsia in 1 out of 7 women. Who's at risk? Are patients who are obese, are patients with a difficult airway, are patients who report snoring or somebody in their family reports snoring, or are patients that report daytime sleepiness. And we as OBs really need to do a better job of simply asking patients this. Certainly also, if we're thinking about that they might be somebody who has to go under, they might have a crash cesarean section, and we should understand a little bit more about their airway before that happens. What happens? When we normally sleep well, catecholamines go down, adrenaline goes down. But if we're having that hypoxemia, if we're occluding our airway frequently during the night, our sympathetic tone is going to go up. And that sleep disturbed breathing, which is increasing just because of the edema and the weight gain as women get into the 3rd trimester, is going up significantly. But there is a solution. And the solution that I've seen most effective is auto-titrating CPAP. So getting CPAP, which is certainly safe and healthy in pregnancy, but getting a machine that can turn itself off or raise or lower the levels can be very effective. We're seeing for patients that don't get that relief, they have decreased, or I'm sorry, the patients that do get that relief, they're having decreased vascular tone, so they're lowering their blood pressure, and they're getting more fetal movement. And who doesn't want more fetal movement? Well, maybe if it wakes you up at night. But other than that, fetal movement is great. We should be looking at our patients who have potential for respiratory depression and thinking about the medications we give them. We frequently give Tylenol with codeine post-surgical patients. And we send patients home sometimes after a day surgery who could still have some of those respiratory sedatives in their system and be worried about their potential for occluding their airway and having respiratory depression. Sleep and birth. Women with less sleep have longer labors, and are 4.5 times more likely to end up with a C-section, as opposed to women that get 7 or more hours of sleep. One of the things I try to do in the hospital is when we're doing an induction, try to tone everything down at night and let our patients get a good night's sleep. They're going to be pushing for 3 hours the next day. A good night's sleep is the best thing we can do. We had an interaction. We had some colleagues come over from China, and they said, of course, you must turn off all the medications at night and let your patients sleep. And no way, that simply doesn't happen in America. We're trying to rush our patients through those inductions, and we need to take our time, let them sleep, and hopefully they can push the next morning. So what can we do in pregnancy? We can be aware of risks, obesity, night shifts, ask our patients about daytime insomnia. We can certainly discuss diet. And many of my colleagues, their diet discussion is simply take a prenatal vitamin every day. We can talk about some of the causes of acid reflux and talk about some of the diet changes that can lead to nocturia. We can talk about getting more iron and folate in our diet to decrease restless leg syndrome. And I'll talk more about sleep hygiene, but this is a brief preview or sleep preparation, as we should call it. Getting on a sleep schedule, keeping the room dark and cool, avoiding screens is probably the #1 thing we're seeing with pregnant women. And then talking about their referrals. If we need to refer them for depression, if we need to refer them for cognitive behavioral therapy, we need to refer them for CPAP, and also having them see an anesthesiologist if they're likely to occlude their airway. That's something we can do more in the course of the 9 months of prenatal care. We should be doing more iron studies. We should be asking more about restless leg syndrome and looking for iron studies. It does seem that if we correct iron levels, which are often low in pregnant women, we can get a step ahead on restless leg syndrome. These other ones we'll talk about more later, referring for CPAP and sleep hygiene. Now I asked this one before, does your team ask about sleep? And I'd say in general, my colleagues are bringing it up less than half the time. Sleep hygiene or sleep preparation. I'll go through the full list here. The bed should be for sleep or sex only. Light should be minimized in a room. One of the things I found in either call rooms or hotel rooms is there are sometimes 5 or 6 devices that have a little light in them. The TV might have a light, the refrigerator might have a light, the phone might have a light, and I'll just go around with towels or pillowcases and try to cover up all the little light sources in the room. To be perfectly honest, I actually bring a mask with me everywhere I travel now to try to be able to get sleep, and it's incredibly effective. What I find with the mask is not only is it helping block the light, but it's almost like a behavioral cue, like ringing the bell for a Pavlovian dog. When I put on that mask, I know it's sleep time, and it often gets me there. Minimizing noise. I work in an urban population in urban Los Angeles, and the amount of background noise our patients have to endure when they try to sleep is pretty amazing. So if they can, close all the windows or something like that, but if they can't, trying to get white noise or having something maybe from their iPhone. I know Gia's in New York, maybe some more of you are in New York. There's a hotel on Hudson Yards, the Equinox Hotel. It's something like, I don't know, what is it, $800 a night? But they've tried to make it sort of a wellness hotel. And they are very proud of the fact that at night, the rooms are 65 degrees, which is an optimal temperature for sleep. Any of you follow this guy, Andrew Huberman, who's a neuro-ophthalmologist. He has a podcast. Talks about going out every morning and try to get those first rays of the sun to retrain your circadian rhythm. There is an idea that if you really get exposed to those first rays of the sun, you'll retrain your body clock. Limiting daytime caffeine. I myself only have decaf after 11 o'clock. So these are things that I'm trying to do, trying to decrease alcohol before bed, staying hydrated during the day, are all ways that we can work forward with this. But none of this is really as good as cognitive behavioral therapy. So sleep preparation, formerly known as sleep hygiene, does it work? It does seem like there's pretty good data. It's not as good as cognitive behavioral therapy, But it does work quite well. I have here 2 points. If you can recall when we talked about the Pittsburgh Sleep Quality Index, optimal is less than 5. Pregnant women are at about 6, but you're getting 2 points of movement on that behavior PSQI, which is, I think, a pretty significant score. If any of you have been newborn parents, we have the brush book bed sing along. I don't know if that has worked for your children, but I think creating a rhythm and a ritual before bedtime and a bedtime schedule does seem to be pretty effective, not just in kids, but also in adults. But I'll also mention here this one other point: the sleep efficiency improved somewhere between 5 to 8%. Remember, we should be at 85%. So a 5% difference is pretty significant if we can get patients over that line. So I do think sleep preparation, as with many things in lifestyle medicine, should be there as the foundation, should be the first thing. And if we do need to move further with cognitive behavioral therapy or medications, we've at least built a good foundation on which these things can work. So I'll add a couple more things that I think are interesting. Gratitude journaling. There is a study of gratitude journaling looking at sleep quality, and it did seem to be quite effective. The relationship between gratitude and the sleep variables was mediated by positive pre-sleep cognitions and less negative pre-sleep cognitions. So simply writing down 3 to 5 things in a journal that you are grateful for that day does seem to improve sleep quality. And as I was telling Dr. Merlot before I got on here, I was actually at a religion and medicine conference today, and really thought some of the data that was presented in that was very interesting. But forgiveness of others, as well as forgiveness of yourself, is positively correlated with better sleep. That is also positively correlated with better health. And it seems as though the benefit on health is mediated by sleep. So simply developing a process for yourself where you're letting go of your own judgments, your own failures, and letting go of the grudges that we hold against others seems to have a very positive effect on our sleep quality. So with that, I'll ask poll question number 4. What tool works the best for you? Covering every light, wearing a mask, meditation, lowering the temperature, no screens in bed, or avoiding caffeine and/or alcohol. I'm wondering if any of us have tried this. I'm seeing, oh, good boy, I'm seeing some great comments in the chat. Hopefully we'll get some time to talk to people about them. I will make kind of one other further comment. Some of this work grew out of, as I mentioned, I'm in the American College of OB/GYN, California district chair. And from California, we've been building this movement focused on physician wellness. One of the things that has come out of this, and many of you probably know this data already, physicians matched for age and educational status have about the same health outcomes as our peers, with one exception, and that is suicide. We have a significantly higher rate of suicide, and female physicians have an even higher rate of suicide. The number that I'm thinking of is an odds ratio of 2.7. If you're a female physician matched for age and educational status to your peers, which is really tragic, really, really tragic when you think about the good work people can do. And I'd say with my colleagues, one of the greatest risks that they put themselves at for that outcome is the sleep deprivation that we put ourselves under all the time. So if we can generate some basic tools to help ourselves sleep better, it certainly worked for me in my life. My sleep is significantly better than it was when I was starting as an OB/GYN. I think my mood has been better. Hopefully we can do some good work for everyone out there. And with that being said, I'll take time for some questions. Thank you so much.